us. I want to thank the committee, who is Marianne Donahue, Jack Condon, and our newest member, Dawn Curry, who we thought would be a great addition to the committee. As a prior educator, she's bringing new, fresh ideas to us. And she was nice enough to put together a survey, which I'll have her talk a little bit about at the end of our meeting. But I would like to get started because Captain Mahoney is joining us. We asked him to come back because at our spring conference, which many of you attended, he went over a lot of things. We want to go into more detail because at the end we noticed there were still a lot of hands up. So I'm going to start by asking him some questions that the committee came up with. And then I will ask you guys all a favor. Please mute yourselves. And if you have a question, either raise the virtual hand or raise your hand. I think I can see everyone on the screen. If I don't, somebody on the committee can let me know. But please mute yourselves because we don't want any extraneous noise. So, Captain Mahoney, thank you again for joining us yet again. And some of the questions that the committee came up with were, if you could just quickly tell us, and this is the main purpose of this, is to get information about how you and, say, the police department make a situation non-threatening and decrease the anxiety for a non-English speaker so that we can pass this on to our students. So, first question we came up with is to pass on to our students. When are the appropriate situations to call 911 and which are not?
Thanks for having me here this morning. Hopefully I'll be able to answer any and all your questions. And if I can't, I'll do my darndest to get the information to you. So with regards to your first question, I think, well, a couple things. If I'm hearing you correctly, perhaps the fact that someone speaks another language would, in a lot of ways indicate to me that their upbringing was from a different country and probably a different culture. And so culturally, what does a 911 response look like in South America as opposed to Southeast Asia, as opposed to the United States, right? So for me, I can't really answer those, how a 911 system is run or not run in a foreign country, other than the ones that I've visited and utilized once in Italy. But here in the States, really the quantifier for the 911 call, and this sounds or seems self-evident, anything that just seems emergent. Now, there can be varying degrees of that, again, depending on the person, their cultural background, their history, their life experience, all of it, right? It sort of comes to bear in the moment. As corny as this might sound, there's that sixth sense or that gnawing feeling, we all kind of get in our stomach, the pit in our stomach. I think really being in tune with that and aware of that. And if something doesn't seem right, or something doesn't feel right, or something doesn't look right, then that warrants the 911 call, just as a broad overview, okay? Getting into more specific types of things, and we'll talk about the medical piece. I think like a fire is self-evident, right? Like something's on fire, you should be calling 911, whether it's in the home, outside the home, like get us rolling, get the fire department rolling. Something that seems suspicious or, you know, in the realm of like law breaking, if you will, then that warrants a 911 call, and then you would get a PD response. Now, there's instances where the two of our organizations come together on a call. And a typical classic one is a medical aid that requires intervention because it's our safety. When I say our, it's the fire department's safety is paramount in that situation. These are typically domestic abuse type calls, domestic violence type calls, any type of violent type calls, drug or alcohol related, or anything that just seems suspicious to the 911 dispatcher. So there's definitely quantifiers, and then there's specific ones that we both will go on the call together. I think when it comes to like minor medical problems, so those are sort of like major. When minor medical problems, like the cut finger, the stub toe, those may not necessarily warrant a 911 call. Do we get those calls all the time? And a lot of that, again, has to do with this is a first-time user, the person's just not sure, there's something about it that doesn't seem right, and so they trust that intuition, and then they call 911. And then when we arrive on scene, that's when we assess, all right, what type of call is this? And again, we'll get into the medical world. That's the majority of our calls, about 80%. Okay, does this warrant some sort of emergent intervention, or can we address the issue, mend the wound, you know, give a mild medication like an anti-nausea medication, and then we can either have a discussion about, well, does this person really need to go to a hospital, an emergency room? Can they stay at home? Can they go by private vehicle? So these are some of the conversations that we have in the moment with the patient. Obviously, the foreign language piece or non-English speaking piece can create some bumps along the road in the moment with this call. I'm pretty sure when I was in-house with you guys in Torrance a few weeks ago, you know, the 911 dispatchers, they have a service where they can utilize, they identify the language that's spoken, and then they utilize that service, and a third party comes on that speaks the language. And then there's a three-way conversation between basically an interpreter between the 911 caller and the dispatcher. That same service can be utilized on scene by us. We just call our dispatch center and we can have that conversation.
That brings up, Captain Mahoney, I'm sorry to interrupt you.
No, please.
That brings up a couple of things that we discussed. And one of them is when a person, non-English speaker, first calls in, as far as what the dispatcher asks, what would the person calling in for us to impart to our students? Does the dispatcher want to know what the issue is or what the language is first? For instance, do they say chest pain, Japanese, help, or what? And then what does the dispatcher ask once there's a translator on the line? What should they be prepared for?
Sure. So let me just, I'll put a bow on the last one, on the last question, and then we'll get to that one. At the end of the day, if call 911, if in doubt, and then we'll come and we'll assess whether it's English speaking or non-English speaking. And I think, at least culturally, for some of us, at least here in America, and maybe from other countries, you may feel you're bothering us, or it's not a proper utilization of the 911 system. Like that's okay. Like people overuse the system, and we do have our regulars, if you will, and we manage that. You know, we have sidebar conversations, and how do we get this person really? We get into other avenues of help with those types of individuals. But bottom line is, if in doubt, call 911, and we'll assess and manage from there. getting to your second question. So yeah, I mean, if what happens is it's no different from any other interaction that I would have, let's say just walking on the street and someone randomly needed my attention for whatever reason, and they were non-English speaking, right? There's this interaction where the first few seconds we're like feeling each other, like, okay, this person's clearly not understanding me, or I'm not understanding them, right? And I would imagine most people would revert to their native language. So you get a 911 call, and either it's obviously a foreign language, or there's intermittent or sprinkling, I'll describe it as you put it, of English, like Japanese chest pain, or some indication that there's going to be a language issue. Once that's identified, and I would imagine that's usually identified, again, within the first, call it 10 to 20 seconds of the call. It's just, that's part of the process, right? It's unfortunate, but there's going to be a slight delay in sort of like getting our arms around, okay, we got to fill in the gaps with the communication piece. The dispatcher should be in tune enough. Okay, there's obviously a language barrier here. They will dial up the service provider will attempt to identify the language, and then they'll get the person within the service that speaks that language to converse. Sometimes there can be issues with that service. Sometimes even with the service, there's just, because of the nature of the call, it's 911 in nature, the person's probably not, they're not utilizing their rational brain, they're using their primitive brain. So a lot of the dialogue is very fast paced. It can be broken, confusing, it doesn't make sense. And we even get that with English speaking people, depending on the nature of the 911 call. And so while information is valuable and we like to get as much as we can, sometimes there's gaps and missing pieces, and dispatch will just send us anyways. And they'll tell us over the radio and on our MDCs on our computers, language barrier, unknown type medical. Dispatch will define it and communicate to us that we don't have all the answers. We just know there's an emergency going on at this address. And sorry, there's a helicopter going on in my office. And that it needs to be addressed. And that would be another circumstance where PD would dispatch with us as well, or vice versa, because we're not sure what the nature of the emergency is. So if that makes sense. As far as information provided, I think you had asked that as well, the tail end of your question. A lot of times the dispatcher will they will lead the discussion. So in other words, you call 911, dispatcher picks up the line, 911, what's your emergency? Okay. And sometimes, right, a beautiful story is laid out. It's a calm environment, whatever the problem is. Other times, again, it's all over the board. And so that's where the skill of the dispatcher comes in to really guide the conversation and try and paint a picture. Okay, what exactly is going on here? And what is the emergency? And so okay, let's take chest pain, for example. All right, well, when did the chest pain start? Are you having trouble breathing? Do you have a heart history? They'll ask some sort of basic pertinent questions, but that'll be about it. They're not going to get into a long, drawn-out story. They just want the Cliff Notes version of whatever your emergency is, and then when we get there, we fill in the gaps. Unfortunately, with the inability to speak fluent English in this case, that'll just, if the service can't provide the information, the language speaking interpreting service that dispatch utilizes can't fill in the gaps, well, then we just go into the call with some gaps and we try and fill them in once we get there. So it's not a perfect process, but the nature of emergencies, by their very nature, they're dynamic events, whether it's an English speaking person that's involved, a non-English speaking person that's involved. And then depending on the nature of the emergency, the language really is irrelevant in some cases. If it's a severe trauma, are they semi-conscious or unconscious? One of the easiest patients to deal with is an altered level of consciousness. Could be a myriad of reasons of why that's going on: low blood sugar, infection, head trauma, you name it. But typically those people are confused, or they're unable to even speak, even if they're English speaking. So we just take vital signs and we just start triaging and treating based on those vital signs. So a lot of this, in a perfect world, we'd love to have as much information as possible. But if we have, again, what I'm calling sort of gaps in the information process gathering piece, then we just try and fill those in when we get there.
Okay, so that brings up the next question. So let's say that the dispatcher, they can't determine the language, and you guys just come in.
Yeah.
And maybe it's a call where emergency services and the police have to come in. What do you do then to, obviously, as you mentioned in the conference, it's usually big men in uniforms coming in, and we don't know what their experience is in their country. How do you allay their fears? How do you deal with them to make it a non-threatening situation?
So that's a fantastic question. Just before I address it, and it's interesting, internally, and I'm sure this is pretty universal or amongst most fire departments, when the rookie or new person comes in, when the firefighter 5 years, 10 years down the road promotes to a captain, when the captain promotes to division chief, so on and so forth, the focus, and even in paramedic school, the focus is 95 to almost 100% on operational proficiency. Can you do the job, whatever it is? Unfortunately, right or wrong, because of we need to get people up and we need to get them operationally competent on the floor, working and doing the job, the humanistic communication piece is rarely addressed. In other words, how do we interact with people in a competent way? Okay, it's one thing to pull a hose and put water on the fire, throw a ladder, start an IV, all those things, those skills, which are necessary, but that's rarely addressed. And I think what you're speaking about is bedside manner. And most of us, if not all of us, got in this job because we want to help people. And so that nurturing sort of mindset comes to bear in those moments, which is a good thing. But we're all human beings and none of us are perfect. And sometimes we hire individuals that are grumpy bears, to put it mildly. And even sometimes nice people are grumpy bears because now they're on day 4 and they're working 6 days in a row. So when we come in, and it's interesting, like PD will usually secure the scene first. So if we get a non-English speaking person and we have those gaps I mentioned, PD should be coming with us because there's some missing pieces. This is actually a safe environment. It's got to be safe before we do anything. So PD will come in and they'll do a quick evaluation. They'll establish some sort of interaction or communication, whether it's verbally, I understand if non-speaking English, there's a major gap there. And then there's a conversation with dispatch. Hey, send in fire, like the scene is safe, let's bring them in. Usually in those instances, PD withdraws themselves because they acutely understand the nature of what they do. And I think culturally, it's probably universal in most countries. PD is a law enforcement piece. And depending on the culture and country in which you're raised, whether you come from an authoritarian government or a culture that fears, the police present because police are abusive, they're not, regulated, called to task, they do whatever they do willy-nilly, there can be a lot of fear and apprehension about interacting with the law enforcement if they're aware in that moment. Usually, clues, there's a gun on their side, they're big, burly people, like, hopefully there's those associations. So we'll come in, but even though we're big and burly, we come in physically, we look like the equipment we carry, it's in the insignias, the patches, we can look like PD, but it should be hopefully obvious that here's another element to this. And we engage that way. Now, I think the bedside manner piece, it just comes with time. And from my viewpoint, in the interactions I've had with young medics and young firefighters, again, the nature of the job brings out this sort of nurturing piece, but it's not always perfect. I've viewed it over time that grows. As the human grows, they become sort of softer, kinder. They're able to move in and out of different ways of communicating, and they're more acutely aware of like things like body language, how people are reacting. So they evolve from the operational piece into the more humanistic piece, because those skills become very proficient, the operational piece. So in order to get to a place where I can start my evaluation and like start a blood pressure, put an EKG on the person, that's how the rapport is established. Again, there's no specific training to this in paramedic school, in fire academies, which, you know, my personal opinion is unfortunate, but at this point, and it always has been, is what it is. But these are conversations that we do have after we finish the probation, after the initial sort of skills phase, the rookie year, whatever you want to call it. You know, as we're massaging and building the rapport piece in the bedside manner, we have conversations during our evaluations, quarterly, yearly. If that's a piece that's missing from the medic or the firefighter, it's incumbent upon the captain to have a conversation with that individual, or senior firefighters, or firefighters that are known to have good bedside manner, to model that example. And so we pair those individuals that are maybe rough around the edges with individuals that are a little softer around and have better soft skills. And so it's a very imperfect, it's more of an art than a science, but that's what that looks like from the fire department perspective, and that's how we interact. So whether it's through our own body language, and really respecting space initially, our tone of voice, being acutely aware of these things, this is what comes to bear in those moments and hopes to bring down the anxiety level. Now, if it's a severe mental health crisis, there's other things we can use medically to address that. And in some cases, depending on the severity of it, if we can't get the person to calm down, or we can't get them in a space where, at least from a body language perspective, like I think that's very universal. I think you can look at someone, at least for me, in my experience, this person looks nervous to me. This person looks scared to me. This person looks angry to me. Through the words they use, the body language they exhibit, and just sort of the environment that we're in. I take all those clues, and I can sort of evaluate if something, again, now I'm trusting my gut, something's not right here. And I don't know what it is, but we can't get this person to calm down. There can be more physical interaction where we have to hold the person down, we put them in restraints, we give them medications, whether it's an antipsychotic or a sedative, to get them so we can start treating them, especially if they've got a severe trauma, an airway problem, because these more severe medical problems, those need to be managed. The situation I'm speaking of initially, these are more benign, calm environments. There's a problem here, but we don't really need to jump in and start being physical. There's other situations where we do, because it can be a matter potentially of life or death. I think where we get outside of the realm of that, the classic example recently is the George Floyd incident, right? Where now, and I don't want to go down the rabbit hole too far in that opine, but just as an example, you've got a police officer. However that interaction took place, the perception was that there was a threat to him, and we can debate whether it was right or wrong or whatever, but this is what happened. But now that police officer is gone way beyond what's required for this instance, right? So he's using a hard skill or a soft skill potentially was required, or at least the initial hard skill, like, let's get this person on the gurney in soft restraints, and then let's literally like let go. And now we can start sedating. We can do other things to get them to where we can treat and bring the whole temperature, everything down. So does that answer your question?
Yes, and Jack has a question, so
Sure.
let's hear that.
First, Sheila, I don't know who is in charge of the screen, but I wonder if you can adjust it because you cannot see the people at the top. At least I can't see them. So that's one thing. Second thing is Don had a question, and I have a question too. We were talking about obstacles that might prevent someone from calling 911. An example of which would be that would be a person in authority. They'd be in uniform, they'd have a badge, they might have a gun and so forth. So that might hold people back. But the other thing that I've become aware of is that the cost of calling might call people back. I heard of an incident where a person actually called for an Uber rather than an ambulance when he was run over by an automobile because he was afraid of the cost. So my question has to do with, first of all, is there ever a charge for the paramedics service itself? Second, when you call and you have a medical, let's say, chest pain problem, does an ambulance automatically come? And so is it, how shall I put it? When you call, you are in fact agreeing to an ambulance charge. And finally, does a person who is seriously ill still have the option of not going to the hospital if they choose?
Okay, Jack. So sounds like we've got 3 questions there. I'll try and answer them best I can. So let's start with the first one. And are you charged for paramedic services or when the fire department shows up? It depends. It depends what city you live in. In the city of Redondo Beach currently, there's no charge for the paramedic service. You call 911, we show up to your house, we assess, we treat, we have potentially a conversation around whether or not you need to go to the hospital, want to go to the hospital. And so that up until that point, there's no charge in the city of Redondo Beach. That could be, you may get charged in Torrance. I know you get charged in Manhattan Beach. That's where I live, and we've used 911 twice since we lived there. Once for my little man when he had a breathing problem when he was 3. Another time for my wife, and we got a charge from the fire department. So it depends what city you live in. Just go to the website of that city, specifically the fire department page. You should be able to get the information there as far as charging for paramedic services. So the answer to that question is it depends. Secondarily, you asked about ambulance. That depends as well. The ambulance service, at least, again, I can only speak to the city of Redondo Beach, is contracted out. The contract is owned or utilized by McCormick's Ambulance Company. They have the contract with the city of Redondo Beach. When you call 911 for a medical emergency, yes, you will get an ambulance dispatch. You will get a fire unit dispatch and you'll get an ambulance dispatch in the city of Redondo Beach. Once those units show up, there's no charge. The charge for the ambulance starts once the gurney goes in the back of the ambulance with your body on the gurney. That's when the meter starts running, for lack of a better term. But just the ambulance by itself showing up, there's no charge, at least in the city of Redondo Beach. Again, it can vary depending on what city you live in, what state you live in, right?
Thank you.
So yes, you will get an ambulance. Yes, you will get a charge if you get transported in that ambulance, okay? And then the third piece, your third question, is, I believe it was, do you have to go to a hospital? What sort of is the quantifiers or what qualifies for that? We cannot force any patient to go to the hospital. We cannot force any patient to receive treatment in their house, at work, wherever it is we show up, unless they have an altered level of consciousness, which is defined by their inability to answer some basic questions. Do you know your name? Do you know what year it is? Do you know what city you're living in? If you can't answer any one of those three questions, that's a problem. And the reasons, again, can be myriad. A self-evident one is a severe head trauma. There's probably internal bleed. It's affecting areas of the brain where you just can't simply answer those questions. A stroke is another one, right? Expressive aphasia. You can think the words, but you can't get them out. Low blood sugar in a diabetic. They can't, their sugar's so low, they're semi-conscious or in some cases unconscious. So severe alcohol intake, severe drug intake. These are common situations where you have an altered level of consciousness. If you have an altered level of consciousness that we determine, and it's defined through LA County policy, we have the right, you lose your rights as a patient. We are now your advocate in those situations, and we take over your care. Now, if there's other family members on scene, we can have a conversation about that. Sometimes we get in a situation where there's an altered level of consciousness. Someone's had like 4 drinks. They've fallen, they've hit their head. It's a minor like bump. It still doesn't mean they can't have internal head trauma, but they're not, or they're slow to answer. They're still a little off. Well, now we've got a wife that's on scene. I don't want him to go. I don't want to pay a bill. I'll keep an eye on it. We'll have them sign out against medical advice. We'll have the wife sign out. Okay. So there's kind of a unique situation. So we can't get into these sort of gray areas with this, but altered level of consciousness, that's a red line in the sand from us from a treatment perspective. If you're not altered, you can refuse any kind of, I've had patients where we're seeing an active heart attack on the monitor based on what we're seeing, and their symptoms are exhibiting. You are currently having a heart attack. I had a patient that didn't, for whatever reason, we could not convince this individual to go to a hospital. Okay. To be quite frankly, I don't know what ended up with that patient. So we documented everything. This is a very rare and severe case, but it can happen. I've been on a 4-year-old with a history of epilepsy that was seizing for 20 minutes. So we witnessed the father was on scene. They administer medications to this kid all the time, anti-seizure medications. He was just having a really bad one that day. They were so tired of going, right? This is their normal. And they go to the hospital all the time. And this is getting back to the first question where, man, you're just sitting there watching this kid seize, and the dad's like, I don't want to take him. I can't do this. I can't put him through this again. And we're all just sitting there, right? And so, but we're documenting everything. Eventually, now in that case, we convinced the father, hey, this is a long, even you can agree, this is a long time. Something's not right here. Let's get going. Let's get him to the hospital. And so he finally agreed. But we can get in these situations where if there's an immediate family member, that's husband, wife, brother, sister, father, mother, that can refuse treatment for the patient, right? That's the advocate is there. It's extremely rare, but it does happen.
Thank
So
you.
did that answer all 3 of your questions?
It did very, very well. Thank you.
Okay.
Yeah. And then Dawn, Jack said you had a question.
I'm good. I'm good.
Okay,
I'm good.
I
You answered
can
it.
see, everybody. So I guess we need to wrap this up, and again, very, very informative. But does anybody have any last questions for Captain Mahoney? Maureen?
Okay, can you hear me?
Yeah.
Yes.
I do have a question. Does the question of insurance ever come up? Because that could relate to transporting by ambulance and whether their insurance covers that or not. Do you ask that question?
We do. We ask the insurance piece, though, that we ask, it's not in order to qualify for a ride in the ambulance or just to see if they have it. We just need it so the hospital can have it, and so they can direct insurance, and then the ambulance crew will take that information, because a lot of insurers will, depending on what sort of plan you have and deductibles, they'll cover the ambulance ride as well. And I appreciate Jack's question, and we kind of tie these two together. I don't think I sort of cleaned this piece, and this, just to your question, Maureen. A lot of individuals, whether they're English speaking or not English speaking, the economic piece is that's a thing, right? And they like, how am I going to pay for this? It's just like, oh my gosh, if it's let's just define it as an acute event, medical event, or a basic medical event. The basic medical event, we can have a conversation in the moment. Now I've got a patient, English speaking, non-English speaking, that's apprehensive, like, I don't want to pay for this. Did you know, this is where the education piece comes in, because a lot of people don't know. There's opportunities, depending on which hospital we send you to have the bill covered. Now, that's going to require the patient to interact with social services, with hospital administration, and fill out probably a lot of paperwork and jump through several hoops. But if you want to go there, it's available to you. A lot of people don't know this. Harbor General Hospital, UCLA Harbor, off of Carson Street, which is a county facility. And Little Company of Mary locally is a nonprofit. Depending on your income level and a bunch of other qualifiers, the income level is the big, really quantifier, right? Do you have the money to pay for it or not based on your income? But even that, if you're above that, there's other qualifiers that you can have a conversation around, whether it's payment plans, whether it's part of the bill paid or all of it, where that can be facilitated. So if we're in a situation where it's a sort of a benign medical call, we can have those conversations. And maybe you just want to go to your primary care physician or a non-ER, because that can get really expensive. Maybe you just want to go to the care station, EXA or something like that. Sometimes the benign medical starts off that way, and now it's getting more progressive, like the chest pain. Well, is this muscular chest pain, or are they having a heart attack? Well, we start doing our diagnosis, we're looking at them. Well, actually, there's a good chance this person's having a heart attack. Hey, listen, if you don't do this, there could be some severe consequences up until death here. So sometimes that conversation will lead to like, hey, I need to take care of this, and I'll figure out the money piece later, right? But again, it just depends on the individual. But there are opportunities for individuals, families to have bills either covered 100% or partially paid for, depending on the facility they end up in. But it requires legwork on their end.
And I also called Torrance Memorial, and they do also have a program.
Yeah, they're a little company, just the fact they're the way they're set up, and Harbor General, the ones that most, but all hospitals, yeah, it's just, you got to have, it's just like when you get, I don't know if you do, my wife was in the health insurance business. Like we get an EOB in the mail, like we never pay it. We never pay the first bill. You can always negotiate things down. Like the first bill is never the final bill. And I don't think a lot of people know that, especially people that are here for the first time. Like sort of the intricacies of our medical care services, our healthcare system. It's very, I mean, I'm sure I'm singing to the choir. It's a maze, right? But if you hook in with, typically it's social services, and you begin to have conversations, and if it's, again, the language piece comes to bear here, or lack of the inability to speak English, but at least if there's an awareness piece that's out there, if you can tell that, the tutors tell that to their students, and maybe we can even get someone from the administrative side from the hospitals to come over and have a conversation about that to help them navigate those avenues. So,
okay. My other question, I do have another question. So Redondo Beach is contracted with McCormick. So
yes,
when there is when there's an emergency and it's deemed that the decision is made that the person needs to be transported to a hospital, is it the closest hospital, or the hospital that McCormick would have a contract with in order to bring that patient to that hospital?
That's a great question. So just so we're clear, the ambulances don't have contracts with the hospitals. They have contracts with the cities that they serve. The destination of the patient is determined by several factors. Every area or every city, if you will, has any number of hospitals in them, right? Whether it's one, I mean, city of Los Angeles, there's probably a dozen of them, right? Here, Redondo Beach, our closest two are in Torrance, Little Company and Torrance Memorial. Little Company, for the city of Redondo Beach, Little Company is called the MAR, or the most accessible receiving facility.
Okay.
Let's call it the majority of patients that end up being transported in the city of Redondo Beach, they end up at Little Company. It's the closest hospital. The far south end of town, it can be debated whether or not, you know, if you're off Palos Verdes Drive, if you're familiar with the area, South PCH and PV Drive, you're about equal distance to Torrance Memorial and Little Company from there. But almost everyone goes to whatever city you live in Los Angeles County. Again, we're just talking LA County. It's different cities and different counties and different states have different systems. LA County, you go to the MAR. If the MAR is closed to ED, it's called ED saturation. They literally don't have any beds. Then you go to the next closest, which for us would be Torrance Memorial. If a patient has a certain issue, so certain hospitals, some are stroke receiving centers. Some are cardiac receiving centers. Like they have cath labs where you can go in and you can have, whether it's an ablation or a stent put in, whatever it is. So certain patients go to certain hospitals based on the hospital's ability to receive that patient and their medical problem, and your ability to get there. We, the fire department. Little Company in Torrance, they receive almost everything. They're EDAPs, which is Emergency Department Approved for Pediatrics. They have stroke centers. They receive heart patients. They're really one-stop shops. The only difference, now not every hospital is like that. The only other difference is a trauma patient. If someone has trauma, and there's varying degrees, gunshot wound to the chest, severe head injury with altered level of consciousness are two examples, where that patient will go to the closest trauma center. The closest trauma center is Harvard General, UCLA, off of Carson, off of 110 and Carson Street. The rationale is that patient, due to their symptoms and the mechanism of entry of their trauma, they're probably going to need immediate surgical intervention, whether it's to diffuse a brain bleed in the case of the head trauma, or the gunshot wound to the chest. Like that's an internal problem that needs to be managed with a surgeon. They have surgeons on site, like operating rooms ready to go. The patient will get wheeled in the ER, a quick evaluation is done, they're sedated, they're taken to the ER, and that problem's managed. So that's the reason, rationale why we go where we go and what we do.
Well, that doesn't make sense. My last question is, say for instance,
the ambulance will just take them wherever we tell them to go.
Wherever,
Like,
okay.
we're going
So
to
say
Harvard.
for instance, the patient is conscious and you ask the question of insurance and they have Kaiser, of which I do. Now, Kaiser has its own hospital. So what happens then? Even though Kaiser is the furthest away.
So that's a great question and an interesting one. So one of two things will happen. Either A, again, if the medical situation is severe enough, like an airway issue or whatever, they're going to the MAR, and we'll kind of figure that out on the back end. If it's a benign medical, we'll either A, try to honor their request. So this would be called a basic life support run, where just the ambulance, a paramedic doesn't follow up. We'll honor their request. You want to go to Kaiser South Bay, Kaiser Harbor City, you got it, no problem. We can't take them to like Westwood or UCLA or USC, right? But that's the closest Kaiser, we do honor that. The other piece of it is if you go by 911 ambulance to any hospital and you're a Kaiser patient, Kaiser will cover it as long as you go by 911, not if you go by private vehicle.
Okay.
And so in the case of like a severe patient, they end up at Little Company for respiratory distress. They have a severe allergic reaction, they're anaphylaxis, their airway's closing. Get them stabilized, maybe sedate them, get their airway good to go. They're probably going to spend the night in the hospital. If it's longer due to some other physical airway issue, they'll do an interfacility transport from Little Company of Mary to the Kaiser facility.
Oh,
And then again,
Thank you.
Kaiser, as long as you go by 911, Kaiser covers that on the back end. It's just like you've gone to a Kaiser facility. Again,
Right.
there's a lot of paperwork minutia that goes with that
Sure.
on the insurance end, and for the receiving patient, right? There's some I's to dot and T's to cross and a few hoops to jump through, but that's how that
Right.
plays out, what it looks like.
Thank you for that. That's good information, I think.
Yeah,
Yes.
you're welcome.
Okay, so Captain Mahoney, again, thank you so much.
Yes,
I
ma'am.
think we all learned a lot, and we have information also to pass on to our students.
Mhm.
Yes, ma'am.
So good to see you again, and you can sign off. I know you're a busy man, so thank you for taking
No,
your time.
you are my times with you guys. You're the most important thing
Thank
going
you
on,
very
so
much.
we're good. Yeah, no, we're good. That's right, and that's what I tell, we get patients that call and, whether or not the 911 call was valid or not, I mean, we'll go back to the station and kind of joke, under our, like, oh, the broken toe person, like kind of have a laugh about it. But when people come, and I think a lot of times they feel bad that they've called us. And for us, it's like, and I'm sure there's interactions too, where there's fire departments or individuals on fire departments where they're just not nice. Like, why'd you call us out here again? That's happened on our department a few times. It's 3 a.m. It's day 4, and like the human piece of them comes out. They're frustrated. They're tired. I'm not excusing it, but we try really hard to be like, listen, we've got other units. We're good. The person in front of me, you're the most important problem, issue, human being. Like, we're going to deal with this right now. And whatever it is you need to get where you need to go physically, whatever that looks like for you, for us, like, don't worry about it. Like, we're good. Like, we're here to take care of you. Bottom line, period, end of story. That's it. Yeah. So don't ever feel apprehensive, bad. Should we? When you start asking in your mind, like if there's a doubt, shouldn't we call 911? There is no doubt. Call us, right? The very fact that you're debating it, whether you're English speaking or non-speaking, and I get the culture, I get the current political environment. Like, I get it. People, for me, but just know that the fire, I know it's not an easy thing to communicate and understand. Like, there's history there, right? There's layers. I get it. The fire department isn't in the business of like deporting people, ratting on people, to however you want to phrase it. We're in the business of helping people and saving lives. That's our jam. That's what we do. So call us, please. If you can relay that to your students and the people you interact with, I think that'll go a long way. The fire department is here to help, period, end of story. In a lot of cases on the back end, depending on their I've gone through, it may be, some people may be, I've been told that I've been violating people's constitutional rights before. I will go through refrigerators sometimes. And if I see whether it's English speaking or non-speaking, and there isn't a lot of food, and this is a elderly person on Social Security and they're all alone, or it's a new family to this country, hey guys, let's go over to the grocery store, let's rally around, and we don't end up transporting them, right? And we'll come back and let's fill up the fridge. Like, that's what we do. That's how the fire department rolls. So
That's wonderful.
yeah.
That's great. Okay. Dorothy?
I just wanted to get his first name.
Oh, Curt, C-U-R-T.
Thank you.
Yes, ma'am.
Okay. Again, thank you. Thanks a million again.
Anytime.
Thank you.
Okay.
Anytime you need me, you want me to join a meeting, whatever you need, just reach out. Let me know. I'm here for you.
Okay.
Thanks, much thanks.
You got it.
Okay. Bye-bye.
Bye-bye.
Okay, so he's a very special person, and I'm glad that he gives so willingly of his time. But there are a couple of things before we close. Dawn, as I mentioned, was good enough to put together a survey, which you guys will be receiving. So I'll have Dawn talk about that for a couple of minutes.
Thank you. We want to make these tutor talks fit the needs that you have. And so we're sending out a 5-question survey through a Google Doc. You'll receive it the way you normally receive emails from us. And it's just asking, what topics would you like to hear? So feel free, there's some, check boxes, or write some information, because we want to honor your time and give you the information and topics that you're interested in. And if you have any other questions or any ideas you want, you can always email me personally, but you're going to get this survey.
Okay. Also, what we had talked about as a committee is that what we can do and are planning to do during each Tutors Talk is to go over a couple of resources in depth that have worked for us. And we would welcome tutors to also share with us what resources they use and what works for them. And Captain Mahoney is on call 24/7. So the plan B, I was going to go over news for you, and we can do that another time. But I felt, yes, it took up a lot of our time today, and some of it was not exactly what we have for Tutors Talk to impart to our students. But I do think that there was a lot of information that we learned that we can impart to our students, especially about any hospital will work with you financially if it's an issue. And any other comments? Anyone? Marianne?
I was just thinking it would be really essential just to go over this emergency services with our tutees, with someone who comes in who isn't a Native American, and just talk about. He did such a good job of diffusing fear about a lot of things around us. And so we can answer practically any question they might have, but just to bring up the topic so they know that that service is out there and that's meant to be used.
Yeah, that's true. Jack?
I didn't have any further question. I just wanted to thank you for being the person who contacted Captain Mahoney. He has contributed a lot at our offsite and today, and just as Marianne said, this is information that's valuable, that we didn't know, and that we can pass on. So thanks to you in particular.
Yeah, I'm so glad I found him. Anything else?
Any questions from tutors that they'd like to ask?
I guess I can throw in something here. I recently got a request from one of the tutors at the YMCA asking us to get a speech therapist because all of his students want help with pronunciation. And I told him I'd bring it up at Tutors Talk if there was time. So does everybody think we need that? If so, I guess we could put in an ad or something for a volunteer match, and maybe a speech therapist volunteer might show up. You never know.
We had a little flyer there saying about South Bay Literacy Council, and I put that up in the post office. It's still there, just asking for volunteer tutors.
Well, Jim, you're shaking your head no. So yeah, you're muted.
Jim? Oh.
Now, the reason I say no is I thought that was the purpose of ESL was to teach the pronunciation, help, work with them to learn, give exercises or whatever it is to work on the pronunciation. I thought that was our job. I thought that's one of the things we did in class, but
Yeah, I would agree with that. Mary Nell?
Yeah, I would agree with that too, but I wonder if there are some tricks or techniques that are particular to speech therapy that might help us.
Let me
Dawn?
jump in here on speech therapy. Realize that different languages have different positions of your tongue. So as the ESL teacher, you kind of have to be very self-confident and making faces and, get in their face and say no as
Mhm.
and have them recite it back, because they may not have that sound in their language. They may not know that the is rolling of the tongue, and you have to make the sound in your mouth, point out what your mouth is doing, and have them try it a couple times. I think you can ask for a speech therapist, but I think that realize that those are specialized fields and quite expensive.
Yeah. Lynn? You got to unmute.
As a thought, that a speech therapist with some experience with other languages could be a good speaker for us in the future, that could give us tips maybe of how to help our students or help us help our students with those
That
issues.
is a great idea, Lynn. That's a great idea.
So let's put that on our list.
And
Yeah, David?
There are various sites on the internet that have that also. There's one I've used is called Clear English Corner, all one word, .com. And it's a speech therapist, has a number of free videos. She also offers paid courses and so forth for English pronunciation. But the free videos are ample. I mean, there are a lot of them, and well, they were. I haven't been there for a long time, and she's very good at explaining, position of the mouth and whether this muscle is tensed or not tensed. And as Don was saying, the tongue and the teeth and so forth. There's a whole jaw, mouth cavity, and tongue positioning. And then she usually has, if not always, at the end of her short discussion, they're typically 10, 15 minutes, maybe at the most, dedicated to a particular sound or particular letter combination. She has a sort of practice session with varying numbers, 10 and 15, 10 maybe sample words that you pronounce, and then she gives you the proper pronunciation, talks about them. So I find it she's quite good. I don't remember what her name is.
David, could you put that website in the chat so Lainey can get it in?
Yeah, good.
Yeah, I have a tool too I can put in my notes that I send to all the students that I assess. But so I'm wondering if I could put an ad in for a speech therapist to help us at a Tutors Talk.
Yeah.
That's a good idea. The Tutors Talk or at our fall tutor talk, but or before would be great, I think.
Okay.
Yeah.
All right, I'll do that.
And that might be a great speaker we're combining Tutors Talk with the fall conference. So that might be a really good guest speaker.
So, well, let me add on one more. So this specific tutor obviously feels like he needs some help. Is there anybody out there that would be willing to help a fellow tutor with this specific problem? I think he has mostly Asians in his class, Japanese, Korean, probably. I don't hear a whole go, yes, of course I will. So, but those are the kind of questions I have to field every day, it seems like, yeah.
Lainey, I'm just thinking back to our spring conference. I think one of the speakers, it might have been the physical therapist, mentioned that when he was in college, he had a speech therapist to help him learn English. And I wonder, maybe that's where that question came from. If that tutor attended the spring conference and thought, oh, I
have no idea.
Yeah.
That's true. That's true. And one very quick story is that I think sometimes the muscles in the mouth, and David, you were referring to this, it's just not going to happen where the accent goes away, because my Japanese student, we laughed a lot going, oh, making faces and trying, but her tongue is different where she just can't. And so, you know, she practices, but sometimes it just isn't going to happen. And like if we go to another country, you know, I can't roll my R's. It's really hard for me. So, but it is something to consider. And please fill out the survey when you receive it. We want to know. We always are looking for new ideas. And any last minute comments, questions?
Thank you for pulling all this together. I know you're all volunteers, and it can be time consuming to be in a central position like that. But I've just been enjoying this for several years now, and I've had students that I absolutely love. The one I have now is like an angel. She's so sweet. So I just want to thank you for making the program available to me and to the students.
Oh, well, you're very welcome, and we'd love to hear that feedback because there is a lot that goes on behind the scenes.
Mm-hmm.
And we do work very hard at trying to get interesting topics and speakers. So thank you for that.
I just want to add about the tutors having trouble with pronunciation. I know that we do offer, I mean, there's a bunch of pronunciation resources that are out there. I mean, I'd be happy to maybe share some of those, or again, talk to that tutor. The short term, maybe find the right resources that works for them, because I know that is something I always try to cover in the training, but you know, we don't have a long training where I can go in depth into it, but it's possible. It sounds like that's an area they're struggling with. So I would be happy to help. Yeah.
Thank you.
Okay, is that everything? Comments, questions, anything? Okay, thank you all again for coming. I hope this was helpful for you.
Thank you for doing it.
Thank you.
Thanks, everybody.
Bye.